Today we're diving into a fascinating world that exists just beneath the surface of every newborn's kicks and gurgles. We are talking about infant reflexes. These are not conscious decisions a baby makes. They are automatic, involuntary movements. They are triggered by specific stimuli, like a touch or a sudden sound. Think of them as the body's pre-programmed software. This software is essential for survival in the first few weeks and months of life. It's a set of instructions hardwired into the nervous system. These reflexes are the very first ways a baby interacts with their new, strange world outside the womb. They are fundamental, powerful, and tell us a great deal. As an occupational therapy student, you will soon learn that these reflexes are far more than just cute baby tricks. Why do we place so much importance on these fleeting, automatic movements? It's because these reflexes are the essential blueprint for a child's motor and neurological development. They are the first chapter in the story of how a baby learns to control their body. At birth, an infant's brain is not yet mature enough to execute voluntary, purposeful movements. So, nature provides this set of reflexes to bridge the gap. They ensure the baby can perform essential life functions, like feeding and protecting themselves from harm. Each reflex helps to strengthen specific muscle groups and build neural pathways. Think of it like a workout program designed by nature. The rooting reflex, for example, strengthens the neck muscles as the baby turns its head. The palmar grasp strengthens the muscles in the hands. These repetitive, involuntary movements lay the groundwork for the voluntary skills that will come later. A baby who has practiced the stepping reflex will find it easier to develop the coordinated movements needed for actual walking. The reflexes are the scaffolding that supports the construction of more complex motor skills. Integration, the gradual inhibition of these reflexes, signals a maturing nervous system. Let's begin with two of the most critical reflexes for a newborn's survival, the rooting reflex and the sucking reflex. The rooting reflex is triggered when you gently stroke a baby's cheek or the corner of their mouth. In response, the baby will automatically turn their head, open their mouth, and begin to search for a nipple. In clinic, a simple demonstration can reassure a worried mother that feeding systems are working. Once the baby has found the nipple and it touches the roof of their mouth, the sucking reflex is triggered. They will begin to suck rhythmically and strongly, an innate skill present even before birth. You can sometimes see this behavior prenatally on ultrasound. This prenatal practice helps ensure they can feed effectively from birth. In the NICU, very preterm babies may have a weak or uncoordinated suck. This can make feeding stressful for families. An OT might use gentle oral motor stimulation, for example stroking the roof of the mouth, to encourage a stronger sucking response. Understanding the mechanics is crucial for planning feeding strategies. Your interventions will aim to help infants feed, gain weight, and thrive. With targeted support, many infants show rapid improvement and go on to meet feeding milestones. Now let's look at two reflexes that are more about protection and connection. The Moro reflex. It is an automatic response to a sudden loss of support, a loud noise, or abrupt movement. When triggered, the baby will fling their arms out with palms up, inhaling sharply, and may cry. Then they quickly bring their arms back in, a protective, cling-like movement. The Moro is thought to be an evolutionary holdover. Imagine a baby primate clinging to its mother. A symmetrical, full-body Moro suggests normal CNS communication. An absent or asymmetrical Moro can be a red flag. If you see asymmetry, investigate for injury or nerve palsy. Next, the palmar grasp. Place a finger or small object in a baby's palm and watch their tiny fingers curl with surprising strength, completely involuntary. This reflex supports bonding and physical connection between caregiver and infant. Clinically, note presence and strength. It's strong at birth and should fade by 5 to 6 months. As it fades, voluntary grasp and pincer skills emerge. Persistence past 9 months is a red flag. A retained palmar grasp can interfere with releasing objects and developing fine motor skills like the pincer grip. If persistent, include reflex integration strategies in your assessment and plan. The asymmetrical tonic neck reflex, often shortened to ATNR, links head movement to arm and leg movement. It's often called the fencing reflex because of the characteristic on-guard pose. When the baby lies on their back and turns the head to one side, the same side arm and leg extend and the opposite side limbs flex, creating the fencing posture. ATNR plays a role before birth, helping the fetus move and kick in the womb and build tone. After birth, it supports early hand-eye coordination as the hand comes into the field of vision. Repetition helps the brain link vision to hand movement. a first step toward purposeful reaching. ATNR is present at birth, most noticeable at 2-3 months, and normally integrated by about 6-7 months. Integration lets the baby bring both hands to midline, essential for self-feeding and midline play. If ATNR persists, crossing midline, handwriting, reading, balance, and bilateral coordination can all suffer. As an OT student, spotting a retained ATNR early helps you target interventions before patterns become entrenched. Beyond ATNR, there are other postural reflexes that build toward crawling and walking. They act as building blocks for more complex movements like crawling and walking. One is the symmetrical tonic neck reflex, STNR. Unlike ATNR, STNR links head flexion extension symmetrically to limb tone. When the baby looks down, the arms bend and legs straighten. When they look up, the arms straighten and the legs bend, a transitional reflex that helps get into quadruped. STNR helps the baby push up onto hands and knees, enabling crawling patterns to start. It typically emerges around 6-9 months and should be integrated by 9-12 months. If not integrated, the child may bunny hop rather than crawl reciprocally. The tonic labyrinthine reflex, TLR, is influenced by head position relative to gravity and managed by the vestibular system. Supine encourages extension, prone encourages flexion. TLR is present at birth and integrates as head control develops. Integration by 6 months supports head control and postural stability. Finally, the stepping reflex. If you hold a newborn upright with feet touching a surface, they will make stepping motions. It's not true walking, but it strengthens leg muscles and practices patterns needed for future ambulation. Now let's turn our attention to the feet, where 2 important reflexes provide neurological clues: the plantar grasp and the Babinski reflex. If you gently press your thumb against the ball of a baby's foot just below the toes, you will see the toes curl downwards and grip, a strong reflex at birth. This helps build arches, foot muscle tone, and groundwork for standing and balance. The Babinski reflex is tested by stroking the outer sole from the heel toward the little toe. In infants under 1-2 years, a normal response is big toe extension with toe fanning. That pattern reflects an immature corticospinal tract, normal in infancy. After about 2 years, the response changes to toe flexion. A reappearance of Babinski later is concerning. Testing these simple foot reflexes is a quick, powerful way to assess neurological integrity. A positive Babinski in an older child or adult can indicate CNS damage. Act promptly if you see it. A crucial part of your job is to understand what happens when primitive reflexes don't appear or don't integrate on schedule. A retained reflex can act like a roadblock, preventing mature voluntary patterns from emerging. A reflex that persists beyond its typical age is called retained or unintegrated. This can show up as clumsiness, poor handwriting, or difficulty with fine and gross motor tasks. A retained Moro can leave a child in a near constant state of fight or flight, overly sensitive to sound and touch. A retained TLR may cause slumped posture, poor core tone, and balance problems. You won't always be formal testing. Look for these patterns during everyday activities. Spot a flicker of ATNR during sports or writing. It's a clue. Use observations to form hypotheses, then design targeted assessments and playful integration exercises, rather than only practicing the failing skill. In conclusion, understanding infant reflexes is not just an academic exercise. It is a practical skill that forms the bedrock of pediatric OT practice. These automatic movements are the first language of the nervous system, from rooting and sucking to ATNR, STNR, and the Babinski sign. Each reflex tells part of the developmental story. By learning to read this language, you can detect subtle cracks early and design interventions that help children participate fully in occupations. As you move into placements, carry this knowledge. Observe every child with curious eyes. Look beyond the obvious. Is the movement voluntary or driven by a primitive pattern? Your insights will make the difference.